Well, good morning, ladies and gentlemen. It is 9:25. So if we start our activities, welcome to the first video course on clinical cardiac pathology. We're a relatively small audience who are here for the demonstrations themselves, but this is our first attempt to make video presentations of cardiac pathology. So clearly we're hoping that what we produce will be available to others who aren't here during the course, and you yourselves are well aware that you will receive copies of all the videoed material which we will demonstrate of the normal heart, the congenitally malformed heart, and the heart with acquired disease. We're feeling our way, so this is a prototype, so we hope you will all bear with us if mistakes do occur, which inevitably they will, but hopefully not too many. I should start off immediately by saying how grateful we are to Cordis for making it possible for this video to take place. In this respect, we owe Chris Brown and his team from the United Kingdom a very big thanks, and we're also particularly pleased that Andrew Zach from Cordis International in Brussels with the international division is here, and we also thank you, Andrew, for your support over the years. And Cordis have been very supportive of us in previous video ventures. They were very generous to us at the World Congress of Pediatric Cardiology in Paris, and we made, I think, 4 very nice videos there, and this is a continuation of that. And we hope that in the years to come we will produce a formidable library of videos, of educational events from our stance looking at pathology of the heart, but in the time to come magnifying this very much to clinical, to cardiologic, to surgical aspects. For today's course, I'm also particularly indebted to my very good colleagues and friends who you will be seeing as we go through the course. Anton Becker, who you will see next. Anton, as you know, is from Amsterdam. We've worked together for a very long time, and he, at the present time, is our British Heart Foundation visiting professor, and we're grateful to the Heart Foundation for their support also. Michael Davis, who, like myself, is supported by the British Heart Foundation. Michael is based at St George's Hospital, but now has a very close relationship with us at the Royal Brompton, and we're very pleased that he's been able to make over one day of his week to spend time with us at the Royal Brompton. And then we are supported by our own very close colleagues, Yeho, who, as everybody knows, does all my work, does a significant part of Professor Becker's work, and she has been mainstay in getting the material together for this course. Mary Shepherd, who is Senior Lecturer at the Royal Brompton, and Jessica Mann, Lecturer at St George's, and also spending time now and completing the team. And you will be seeing all of us over the next 2 days. You'll also note that we have quite sophisticated video capabilities, and to that we're very grateful to Andy and to Jeremy of Video Group Medical. They are sitting at the back of the room. They are making everything work. They are keeping us all in order, and we're very pleased that they're with us to give us their professionalism, and we hope that we will be able to match their professionalism as we were from the front of the room. As far as possible, we are going to demonstrate hearts to you with the television camera. And the cameraman is equally important in this respect, and as you'll see, he will keep you very close in to the heart. Because we are preparing this course, hopefully for recycling in its video format, we are going to try to capture the didactic material in 45-minute slots. And we hope that over those 45 minutes we will be able to retain a degree of continuity. But you will see from your program that after each 45-minute slot, and I hope that all of my colleagues like myself will manage to stay within the time, after that 45 minutes there is 15 minutes for interactive discussion. So if you will bear with us and try and keep your comments and your discussions for the 15-minute discussion slot, and then at the end of each day we have half an hour set aside for comments, for you to make your points, and at that time we will also be able to bring back any of the hearts or any of the slides or any of the diagrams we have shown you during the day. So now, since it is now 9:30, and since if I am to keep to my promise and keep to time, it's necessary for me to sit down at the front and start off with a consideration of normal cardiac anatomy. Now your attention should focus very much upon the television screen, because all the action is coming to you from the television screen. And so let us start our course on clinical cardiac pathology with the basis of understanding, a look at the normal heart. What I'm going to try to do over the next 45 minutes is to introduce you to normal cardiac anatomy as it applies, or as I see its application, to the malformed heart. I will particularly concentrate on its application to the congenitally malformed heart, because that is perhaps the area where normal anatomy is of most importance. But it's axiomatic that knowledge of the normal heart is essential for the understanding of a heart with acquired disease, and of course knowledge of normal cardiac anatomy is absolutely crucial for the understanding of the cardiologist in his day-to-day work, and particularly for the cardiac surgeon. And we're very pleased that in this morning's audience we have a good proportion of cardiac surgeons, and so we will try to look at aspects of normal cardiac anatomy as they relate to cardiac surgery. We also know we have others that are not quite as experienced as the cardiac surgeons and are not as familiar with the inside of the heart, so we hope we don't become too complicated and we try to take things from first principles. So let's return our attention to the normal heart, and let's put cardiac anatomy into its context. Now, of course, we cardiac pathologists have the great advantage that we can take this heart and we can sit it on its apex, we can look at it from the back, we can open it inside out. We have the great facility to take the heart and to look at it as we want to look at it. You who work in the clinical arena, of course, are constrained because you have to work in the context of the heart within the patient. So it's very important that when we look at the anatomy of the heart and when we look at the pathology of the heart, that we think of the heart within the patient. So, wherever possible, we should look at the heart and we should try to understand it in its position as it lies within the chest. And in that respect, we know that the heart has its own long axis. We describe the heart very much in terms of a triangle. We talk of the base of the heart, we talk of the apex of the heart. But we should then remember that the base of the heart is only halfway up the cardiac mass, and the cardiac base is oblique. It is oblique relative to the long axis of the body. And because the base of the heart, marked by my probe at the moment, is oblique to the long axis of the body, so is the long axis of the heart itself. So our understanding of normal cardiac anatomy has to be framed upon our understanding of the cardiac landmarks relative to the landmarks of the body. So the cardiac apex, as you are all well aware, sits in the left part of the chest, in about the fifth interspace, the midclavicular line. The midpoint of the heart probably comes down more or less at that point, so the cardiac mass sits roughly so that 1/3 of its mass is to the right of the midline, 2/3 of its mass to the left of the midline. All the action in the heart lies here at the area that we call the cardiac base. And the base of the heart is the point where the atrial chambers meet the ventricular mass. And very shortly I'm going to show you a picture of this cardiac base looked at from its atrial aspect, because that gives us the crucial information concerning the interrelationships between the valves. And really, cardiac anatomy can be thought of in terms of the musculature of the cardiac chambers acting as a pump, a muscle pump driven by electricity. We'll look briefly at the areas within the musculature where the electricity is generated and how it's conducted. And of course, those muscular pumps driven by electricity have valves within them that coordinate the flow across and through the cardiac chambers. So we're going to look at the structure of these different valves. Here I'm showing you the pulmonary valve. Here you see tricuspid valve. And I'll show you the interrelationship and the differences of these structures. But let's come back for a moment to the overall arrangement of the heart. Its apex, the base, which contains the atrioventricular junctions, the ventricular arterial junctions, the atrial mass, the ventricular mass. Because the key to the understanding of this cardiac anatomy is the appreciation that in this normal heart, these chambers wrap themselves around one another in a very complex fashion. And the right border of the heart is formed very much like by the chamber that we call the right atrium. And here we are looking at the right atrium. Coming into its roof, we have the superior caval vein. Coming into its floor, guarded by a very prominent valve here, we have the inferior caval vein. And if we wish to orientate the heart in its proper position, we put the two caval veins, one above the other, in vertical orientation. The right atrium then, which receives the systemic venous return through those vessels, which also receives the systemic venous return from the heart itself through the hole I'm putting the tip of my probe into at the moment, the coronary sinus. The systemic venous return then crosses the right atrioventricular valve. And here you see the right atrioventricular valve, which, as you all know, we call the tricuspid valve. And that enters the right ventricle. Now if we back off this heart and we look at the position of the right ventricle in terms of the overall cardiac mass, you see one of the problems we have in giving adequate descriptions of heart. Because in reality, this structure, which we call the right ventricle, is an anterior structure rather than a left-sided structure. Because here behind it is the chamber we call the left ventricle, and most of the right ventricle is directly in front of the left ventricle. And indeed, the vessel which emerges from the right ventricle, the pulmonary trunk, is to the left of the vessel which emerges from the left ventricle, that vessel, as you all know, being the aorta. And the key to the understanding of normal cardiac anatomy is the appreciation of this central location of the aorta. Now I can show you that central position of the aorta a little better if we look at this area of the heart which I called the base, which is the plane in which the atrial chambers meet the ventricular chambers, and in which the ventricular chambers give rise to these arterial trunks. And we look at this base by taking away the atrial chambers, by taking away the arterial trunks, and by looking at this base from its atrial aspect. And if I may, I will now pull in another heart which I've already dissected to demonstrate cardiac base. And here now you're looking at such a heart that I've dissected by cutting away the atrial chambers, by cutting away the aorta, by cutting away the pulmonary trunk, and we're now looking at this area which we call the cardiac base from its atrial aspect. And I hope the dominant feature, which is apparent to all of you, is the central location of the aorta. And indeed, it is the central location of the aorta which is key to cardiac anatomy. We're going to talk about this interrelationship between the aorta, the mitral valve, the tricuspid valve, because you can see that these three valves together make a very integrated unit. There is a trefoil arrangement, a shamrock arrangement of the three valves. That is missing in some important malformations, one of which we discussed in the Paris meeting, which we will not discuss in this course, the heart we call atrioventricular septal defect. But Professor Becker will emphasize the significance of this interrelationship between the centralized aorta, the mitral valve, and the tricuspid valve, when in the next session we talk about ventricular septal defects. So the emphasis again, the key to the understanding of normal anatomy, the appreciation of this central location of the aorta, its relationship to the mitral valve, its relationship to the tricuspid valve, and then here you see interposed between the pulmonary valve, the most anterior and the leftward of the cardiac valves, and the tricuspid valve, you see that the aorta interposes between these two structures. And having shown you the base of the heart, if I now return to my intact heart, you see I'm pulling that back in to take you back now to this intact heart, you can now, I hope, appreciate this relationship, the central position of the aorta, and you see how in the right ventricle the sweep of the ventricular mass takes you from the tricuspid valve, which is the most inferior of the four cardiac valves, to the pulmonary valve, which is the most superior of the cardiac valves. And we now see another very important feature of cardiac anatomy, which is apparent to all of those who study the heart in detail, namely that in the right ventricle there is musculature separating in the roof of the ventricles the attachments of the tricuspid valve from those of the pulmonary valve. But if I turn the heart over, and I now show you the left side, you see that on the left side of the heart, that musculature is lacking. So that in the transition from inlet to outlet of the left ventricle, with here the dissected mitral valve, here the orifice of the aortic valve, you see at their point of transition there is fibrous continuity between the leaflet of the aortic valve, the leaflet of the mitral valve. And that is a very important distinguishing feature between left ventricle and the right ventricle. Now, those are the general aspects of cardiac anatomy, a series of muscular chambers, the atrial chambers connected to the ventricular chambers, the chambers driven by electricity, pumps guarded by, as far as the ventricular mass is concerned, an inlet valve, the atrioventricular valve, an outlet valve, the arterial valve. Now you will immediately appreciate that there are fundamental differences between this inlet pump, this inlet valve, and this outlet valve. And the differences in the structure of these valves reflect their function. Because the ventricle fills during diastole when the atrial chamber is pumping blood across the atrioventricular junction. So that during ventricular diastole, the atrioventricular valve is open, the ventriculo-arterial or arterial valve is shut. And the arterial valve, if I turn it over to show you the aortic valve, the arterial valve shuts during ventricular diastole simply by the consequence of the pressure of blood that is carried within the aorta. Because the pressure of that blood forces together these three semilunar leaflets of the arterial valves. And you can see that in this heart that was prepared by Professor Davis under fixation, we've subsequently dissected it to show the valve, but you can see how beautifully these three cusps fit together, and the zones of coaptation between them, the commissures, are kept firmly shut during ventricular quiescence or diastole simply by the hydrostatic pressure of the columns of blood supported by these leaflets. So the structure of the arterial valves with semilunar attachments, which I'll show you shortly, these semilunar attachments together with these three leaflets supported by their sinuses permits beautifully the arterial valve to function as a consequence of the hemodynamics of the pumping chambers. So let me turn back now, and let's stay with the same heart. Let's come back, and now let's look at the atrioventricular valve. Because you see that the arrangement of the atrioventricular valve is significantly more complex. Because the atrioventricular valve, and we're looking now at the tricuspid valve, you can see, if I show you from the atrial aspect, the three leaflets of the tricuspid valve, one adjacent to the septum, which we'll look at in a moment, a very big one here, which we call the anterosuperior leaflet, a much smaller one lying along the diaphragmatic surface of the ventricular mass, we call that the inferior leaflet. So the valve basically has these three leaflets. But the atrioventricular valve has to close whilst the ventricle itself is pumping the blood out and up the arterial trunk. So the atrioventricular valve has to withstand the full force of the pressure generated by the ventricle as the blood is pumped out of the arterial trunk. So the atrioventricular valve is furnished with these complex arrangements of tendinous cords. So the atrioventricular valve also has a leaflet. The leaflets are more semilunar. They are semilunar shaped also. I suppose they are half moon shaped. Their base is attached at the atrioventricular junction. The atrioventricular junction, the point at which atrial myocardium meets ventricular myocardium. And you all know, I'm sure, that at this atrioventricular junction, in addition to the valvar leaflet being supported from the junction, there is also insulating tissue which prevents the activity, the atrial activity, the electrical activity in the atrial muscle passing across the junction to activate ventricular myocardium. So this atrioventricular junction has two purposes. One is to insulate the atrial events from the ventricular events. The other is to support these leaflets of the atrioventricular valves. So the atrioventricular valves have an annular attachment. They have leaflets. The leaflets are then supported by these tendinous cords, or cordi tendinei, and the tendinous cords are attached to the papillary muscles. So this arrangement of annulus, leaflet, tendinous cords, papillary muscles is somewhat more complex than the semilunar attachment of the arterial leaflets. And the reason for that, of course, is that as the ventricle contracts, generates its pressure, so that pressure pushes together the leaflet of the valves, and then we need the tendinous cords to stop the valvar leaflets pushing themselves inside out and prolapsing into the atrium. So the valve is beautifully designed to fulfill, to withstand the full force of atrial activation, of ventricular activation. And we see that similar arrangement in the left ventricle. So here is mitral valve cut across. You are only seeing here half the mitral valve. We call the mitral valve because of a perceived likeness to the episcopal mitre, although that is not immediately evident. But here you are seeing half the mitral valve, and you're seeing one of its leaflets here attached across the musculature of the atrioventricular junction. You're seeing the other leaflet here, which, as we've already discussed, is in fibrous continuity with the leaflets of the aortic valve. And you see that the mitral valve also has leaflets attached at the annulus, has tendinous cords, and has papillary muscles. Now, there are fundamental differences as well as these similarities between the arrangement of the mitral valve, tricuspid valve, and in their interrelationships between the arterial valves. And they enable us to recognize the structure of the chambers. Now, if I can change my heart once more to come to another relatively intact heart, I'd now like to discuss with you the characteristic features of these different chambers of the heart. Because one of the points about congenitally malformed hearts is that these chambers are not always where we see them in the normal heart. Now, thus far, I've called this chamber, which you see is the most rightward chamber in the heart I'm showing it to you at the moment, which receives superior caval vein, which receives the inferior caval vein, which receives the coronary sinus. I've called this the right atrium. But tomorrow, in one of the sessions, I'm going to show you hearts in which the chamber which has this anatomy is not on the right, but is on the left of the heart. So we must be able to distinguish the character of this chamber, not from its position, but from its morphology. And for that purpose we must find within the chamber a feature which is sufficiently constant to enable us to recognize the heart, irrespective of whether it is normal or congenitally malformed. Now there are several features we could take for that. We could look at the attachments of the superior caval vein, the inferior caval vein, or the coronary sinus. But unfortunately, one of the congenital malformations we are often confronted with is when these venous channels go to a position other than this right atrium. Because of that, we cannot, in the final analysis, use venous connections to identify the heart. We could look at the septal structure within the atrium, because if I passed the probe through this relatively thin part of the wall I'm pointing to at the moment, I will go into the left atrium. And indeed, although not terribly characteristic in this heart, the atrial septum in most hearts does have characteristic features. But in other hearts, the atrial septum can be totally lacking. So we cannot use the atrial septum as the final arbiter of atrial identification. So what can we use? We can use the structure of this part of the heart. This part of the heart is often ignored. It is the appendage, or as the old cardiologists used to call it, the auricle, the ear of the heart. Because as you see, it pokes itself around the aorta. And in the right atrium, this appendage has a very characteristic appearance. It has trabeculations or pectinate muscles. It has this very firm muscle bar between the smooth-walled venous part of the heart and this pectinate part of the heart. And these pectinate muscles, here you see the pectinate muscles coming down, extend all the way around the vestibule of the atrium, leading between the venous component to the tricuspid valve. And this coarse, this broad arrangement of the appendage, with this crest marking its junction with the venous component, enables us to recognize this as a right appendage and to distinguish it from, on the other side of the heart, the left appendage, which is the characteristic component of the left atrium. Because you see, the left appendage is really auricular, is really like an ear. It sits itself up. Often it has these two little probes, or these two little diverticuli at its end. The left appendage has a very narrow junction with the venous component. Here beautifully you see the smooth-walled venous component of the left atrium, which, as you know, receives a pulmonary valve, pulmonary vein at each of its corners. The opening of the right appendage is small, is tubular. The pectinate muscles, did I say right appendage there? I meant the left appendage. The opening of the left appendage is tubular and narrow. The pectinate muscles are confined within the appendage, so that when we look at the posterior wall of the left atrial chamber, it's entirely smooth. And I will show you, as I say, when we look at some congenitally malformed hearts, that it is the structure of the appendage that we use to determine what is, in anatomic terms, the left versus the right atrium, or as we call it, the morphologically right versus the morphologically left atrium. we have anatomic ways of distinguishing right and left. We can do that also for the ventricles. How do we distinguish the ventricles? Well, we could look at the valves. The tricuspid valve has a very characteristic feature. Over and above its three leaflets which we looked at a moment ago, the tricuspid valve has this leaflet, the septal leaflet, with its tendinous cords attached to the inlet part of the septum. If I turn this heart over now and show you the mitral valve, you see that because of this central location of the aorta, which we looked at just a few moments ago, in the basal section of the heart, there is a deep diverticulum separating this mitral valve from the septum. And the mitral valve has these very, very characteristic paired papillary muscles. And if we look at the mitral valve from its atrial aspect, we also see that there are characteristic arrangements of the leaflets. The leaflet in fibrous continuity with the aortic valve being much deeper, but guarding a relatively short segment of the circumference of the valve, whereas the leaflet attached along the muscular part of the atrioventricular junction being a much longer leaflet, guarding 2/3 of the overall circumference. Look at that. There is the more anterior leaflet guarding 1/3 of the circumference. There is the much longer posterior, or as we prefer to call it, mural leaflet, because it is attached to the wall of the left atrium. But note also that the mural leaflet is shallow in comparison to the depth of the aortic leaflet. So characteristic features of the mitral valve that distinguish it readily from the tricuspid valve. Characteristic features of the outflow tract, that there in the outflow of the right ventricle, in the infundibulum, this funnel which leads to the pulmonary trunk, the leaflets of the pulmonary valve, which I'm bringing into appearance for you there, are supported throughout their circumference by the musculature of the infundibulum, whereas, as we've already seen, in the outflow tract of the left ventricle, the three leaflets of the aortic valve are supported in part by muscle, the muscle of the septum here, but also supported by the musculature of, are supported by the fibrous tissue of mitral valve, and there is this area of fibrous continuity between the leaflets of aortic and mitral valve. So very characteristic features of ventricles determining coming from the inlet valve, from the outlet valve. But as we will see in one of our subsequent talks, not all ventricles have an inlet or an outlet. So we must, in the final analysis, to determine ventricular morphology, turn our attention to the third ventricular component, and that is the apical component. Now oftentimes the apical component, like the appendage of the atrium, is ignored. But when you look at this apical component, you see it has very characteristic trabeculations. And when the coarseness of these trabeculations in the right ventricle are compared with the trabeculations in the left ventricle, the left ventricular trabeculations in comparison are much finer, are crisscrossing, and it is these apical trabeculations which enable us in the autopsy room always to distinguish what is a morphological left ventricle from what is a morphologically right ventricle. Of course, when hearts have their three normal components of each of the ventricles, we take those into account. But in malformed hearts, it is the apical trabeculations we look at to distinguish and to separate the morphologically right from the morphologically left ventricle. In terms of the arterial trunks, they are easier to differentiate because we look at their branching pattern, and so the pulmonary trunk divides into right and left pulmonary arteries and lacks coronary arteries. The aorta, in contrast, gives rise to the coronary arteries, and from its ascending part, taken away in this heart, arise the brachiocephalic arteries. So there are very characteristic morphologic features of the normal heart which we will take into account when we analyze the malformed heart. Now, to finish this consideration of normal, I would now like to turn my attention to septal anatomy. And I've got another heart here which I have dissected to show particularly the arrangement of the ventricular septal structures, but which also shows rather nicely the arrangement of the atrial septal structures. And Professor Becker will be emphasizing these features very shortly in relationship to deficiencies of the ventricular septum. Now, we also need to look at the atrial structure here in terms of the electrical activity generated within the heart, because this also is going to be important in the setting of ventricular septal defects. I've already said to you that the heart is muscular pumps driven by electricity. The electricity is generated in the sinus node, and the sinus node has a very characteristic position. Here is the right atrial appendage, this typical triangular appendage which has a very broad junction with the smooth-walled atrial component. I've now turned the heart inside out to show you this relationship between the muscular atrial component, the appendage, and the more smooth-walled component, the venous part. And here, joining the two, is a very characteristic muscle bundle which we call the terminal crest. You see the pectinate muscles, teeth-like muscles, come from the terminal crest, like the teeth of a comb. The terminal crest marks the location externally of the terminal groove. And here at the top of the terminal groove, where it joins the superior caval vein, is the crest of the atrial appendage. The sinus node is a small cigar-shaped structure lying immediately subepicardially here within the terminal crest, terminal groove rather, and probably extending for 1 to 1.5 centimeters in this location. The sinus node, which has this characteristic position, generates cardiac impulse, which then passes through the thick atrial muscle bundles, passing around the holes created by the inferior caval vein, by the atrial septum. This depression on the septal surface of the atrium is what we call the oval fossa, and comes down towards the coronary sinus. Within the atrium we see here a very characteristic valve which guards the opening of the inferior caval vein. There is the mouth of the inferior caval vein, and this very characteristic structure guarding it that I'm picking up at the moment is called the eustachian valve, the valve of the inferior caval vein. And it very often, as in this heart, joins together with this second valvar structure guarding the mouth of the coronary sinus, which I'm pointing to with the tip of my probe. And then commissure between the valve of the inferior caval vein, the valve of the coronary sinus, comes together and forms a tendinous structure, which we have dissected in this heart, which you see here, which is called the tendon of Todaro. And that passes through this muscle bar, which separates the mouth of the coronary sinus from the position of the atrial septum, and it passes forward towards the base of the aorta. And this tendinous structure passes down towards the base of towards the back of the aorta, and forms a triangular area here with the septal attachment of the tricuspid valve. And this triangular area, which is called the triangle of Koch, is crucially important for the surgeon, because lying within this triangular area we find the atrioventricular node and its zone of transitional cells. And I'm sure you all know that the purpose of the atrioventricular node is to delay the impulse that has been generated by the sinus node that has spread down through the atrial musculature. And the atrioventricular node delays that impulse whilst the atrial blood is passed across the atrioventricular valves to fill the ventricular cavities. And then, after the node has delayed the impulse, when the ventricles have had time to fill, the impulse passes down and crosses the plane of atrioventricular tissue, which insulates the atrial from ventricular myocardium at all points except one. And that point is here at the apex of this triangle of Koch. And now you can see in this heart, in which I have taken away the right coronary sinus of the aortic valve. Here is the aortic valve. We recognize the leaflets of the aortic valve according to the sinuses they produce, and this sinus gives rise to the left coronary artery. There you see the left coronary artery. This sinus does not give rise to a coronary artery, so we call that the non-coronary sinus. The sinus here which gave rise to the right coronary artery I have removed. But here at the back of and beneath the right coronary sinus, we see a very thin area of the septum. And Professor Becker very shortly will show you this in more detail. This is the part of the septum we call the membranous septum. And because of this wedged location of the aorta between the tricuspid valve, the mitral valve, there in the back of it you can see the ventricular aspect. The tip of my probe is on the ventricular aspect of the anterior or aortic leaflet of the mitral valve. The membranous septum separates the apex of the triangle of Koch from the left ventricular outflow tract. And so the atrioventricular node is able to penetrate through this fibrous area, and you see that it is separated by the septal attachment of the tricuspid valve, so it has an atrioventricular component, an interventricular component. The conduction tissue passes through there and reaches the crest of the muscular part of the ventricular septum. And if I take you back to one of the hearts I've shown you already, you see that the larger part of the ventricular septum is muscle, but that here at the crest, or rather within the left ventricular outflow tract, beneath the non-coronary leaflet of the aortic valve, there is the non-coronary leaflet of the aortic valve. Here is this extensive, smooth area of the ventricular septum. And the conduction tissue, having penetrated through this area of the membranous septum, passing beneath the commissure between the non-coronary, the right coronary leaflet of the aortic valve, branches on the ventricular septum. The left bundle branch cascades down this smooth left side of the septum. The right bundle branch passes back across and emerges beneath this very characteristic medial papillary muscle and enters this other characteristic structure on the right ventricular aspect of the septum, which we call the septomarginal trabeculation of the right ventricle. Professor Becker will introduce that to you in the context of tetralogy of Fallot. So this area of the septum, crucially important for understanding the location of the conduction tissues. And if I just briefly, finally, take you back once more to the dissected heart to show you that again. Here is that small membranous septum. The conduction axis penetrates from the apex of the triangular cock, reaches the crest of the ventricular septum. The right bundle branch passes down in this strap, the septomarginal trabeculation. The left bundle branch passes beneath the mitral valve onto the smooth septal surface and is distributed on this septal surface down towards the ventricular apex. There are many things I have not discussed in this brief introduction to cardiac anatomy, but what I've tried to show you is the basic arrangement of the heart, the basic arrangement of the valves, how we recognize the cardiac chambers, and to introduce you to this crucial septal area, which Professor Becker very shortly will take on to lead you into the first of our congenital malformations, ventricular septal defect.